Morning, everyone. We'll be started in a second or in a few minutes. Morning, everyone. My name is Maria Alcaide, and I am a professor of medicine in the Division of Infectious Diseases at the University of Miami, and the chair of the Inter-CIFAR HIV and Women Collaboration. On behalf of the Miami CIFAR and the Harvard CIFAR, the Inter-CIFAR HIV and Women Collaboration, and my co-chair, Dr. Kate Powers from the Harvard CIFAR, we welcome you to this June 2026 webinar. This webinar features work by established and early-stage investigators who will be presenting on topics that have been previously suggested by this group. Today, we will have 3 outstanding talks, 1 on sexual pressure and 2 on bacterial vaginosis, both topics highly relevant for women living with HIV and also for women living without HIV. As in other webinars, questions can be posted by the audience in the chat and will be answered throughout the webinar. Today, you will also see an evaluation form after each presentation, so please complete it as you see it show up on your Zoom, and make sure you complete before you exit the webinar. And with that, it is my pleasure to introduce our first speaker, Dr. Sonjia Kenia. Dr. Kenia is a full professor of medicine in the Department of Medicine and Public Health Sciences at the University of Miami Miller School of Medicine. She has a bachelor's degree from UCLA and 2 master's degrees and a doctorate from Columbia University. Since joining the University of Miami, Dr. Kenia has led rigorous policy-shaping sexual health research. She has founded the CHAMP HIV prevention program, which is now the county's largest publicly funded street-based sexual wellness clinic, created the InstaCare to improve outcomes for people with HIV, as well as the CREW research training program for scholars from the Virgin Islands. Her work is funded by NIH, Elton John's AIDS Foundation, Sexual Medicine Society for North America, Pfizer, Gilead, and the Florida Department of Health, and has influenced sexual health policies and training across our county and nationally. Dr. Kenia has received major honors and awards, including the Sapphire Award from the Florida Blue Foundation as a Health Equity Champion for Florida, the South Florida's Educator of the Year, and a Legacy Magazine cover, a City of Miami proclamation for mayors, and including also numerous other community awards and medical education awards. She is an avid fitness and yoga instructor at our wellness center, and many of us benefit from having her as one of our trainers. So with that, we are really, really honored to have you today, Dr. Kenia. We are excited and to deliver your talk, Positively Pleasurable, Reclaiming Joy Beyond the Status. Welcome, Dr. Kenia.
Thank you so much, Dr. Alcaide. May I please be allowed to share my screen?
Are you able to share?
Now I am. Yes, thank you. Let me now continue to share, work on these settings. Hello, everyone. Thank you so much for inviting me to do this talk. I'm really honored to be here. And it's very apropos that it's happening today because yesterday was the official National Sex Day. So I hope that you guys engaged in some pleasure yesterday, June 9th, and June is officially recognized as Adult Sex Education Month. So it's very apropos that we're here talking about sexual pleasure in women living with HIV. So, the major problem that we have, and I think that this is widely acknowledged, is that when we address sexual health in all people living with HIV, it really is about preventing forward transmission. And we really don't take into account that sexual pleasure or lack of, it really does impact our overall quality of life. Many of the things I'm going to say today, yes, impact our patient populations, our research participants, but a lot of the things that we're going to talk about in the next couple of minutes, you'll also find they're really relevant to all people, especially women with or without HIV. We all know that person who cuts you off in traffic or in the grocery store line, or that super mean person at work. And we say, anecdotally, like, oh my gosh, they need to get laid. That's like something that we actually say, but science has shown over and over again that the physiological outcomes associated with sexual satisfaction really do contribute to whether someone's a nice person or not. It contributes to our quality of life. When people feel good about their life, they're nicer, they're happier. And sexual pleasure is a huge factor that influences our overall quality of life. Medicine has just failed to address this aspect of well-being in women living with HIV. And while we've been so successful transforming HIV from a fatal diagnosis to a chronic condition, the only way that we really look at sex and HIV, it's really just a series of risks. Have you been taking your medication? Is your viral load suppressed? Do you know how to prevent transmission? And do you want to have a baby? And if you do, how can we do that without the child being born positive? So I believe that sexual pleasure is a human right. And I think in the next 10 years, maybe 20, medicine is going to catch up to this. Remember, females have only been active as leaders in medicine for less than 50 years as leaders, really fully integrated in medicine just over 50 years ago. And so we really haven't had a lot of internal championing of female sexual pleasure. We know female sexual dysfunction it's estimated to actually be the greatest mental health problem in the world, right after substance abuse. And for women living with HIV, most of whom contracted HIV through sexual encounters, the PTSD resulting from sex or the lifestyle that they were living when they became positive, it really has long-term impacts that reduce their ability to advocate for any sexual pleasure. And what we found in some of our research that we'll discuss a little bit later in this presentation is that a lot of women with HIV who are engaging in sex, and many never engage in sex again or haven't begun to. But many who do engage in sex, they really don't understand that sexual pleasure is something that they deserve, and they have been enduring sex with a lot of pain. And re-engagement and feeling sexual desire, this can actually be a clinical indicator of improved mental well-being. So I believe that sexual pleasure could really be used as a diagnostic lens into other areas of our overall well-being. And the science backs this up. We know that sexual pleasure is an indication of mental health, but it's also one of the first indications of underlying systemic issues. It's been widely acknowledged that men who experience erectile dysfunction are probably at greater risk for diabetes. I was one of the first authors who published a paper showing that women who with diabetes also experience significant sexual dysfunction. And it's so different than for women living with HIV. We just haven't had enough scientists championing this. But lack of sexual satisfaction or lack of arousal, orgasmic dysfunction, anywhere in the sexual pleasure cycle, any sort of problems or issues, they really can be looked at as symptoms of larger problems, particularly cardiovascular health. We know that people living with HIV, heart disease is a leading cause of mortality. And we also know that women living with HIV also have increased heart challenges, or cardiovascular health challenges. And we know that a lot of women living with HIV are experiencing, for not the first time, but we're really recognizing it, menopause symptoms. And just like women without HIV, these hormonal changes significantly disrupt or change our sexual functioning. Chronic inflammation that's known to accompany HIV diagnosis is a problem that definitely impacts our ability to optimally function. And pelvic floor functioning with or without HIV, this is a widely known issue that impacts sexual functioning, and our pelvic floor health changes naturally with age. And these are all issues that are not widely addressed in women living with HIV. We all know sexual pleasure can be a mental health indication, actually. And when pleasure disappears, it's often a sign that someone's depressed. Most of us who work in HIV research know depression risk is much higher in people living with HIV, as is anxiety, trauma, PTSD. And for those who have been diagnosed with antidepressants, we all know a major risk factor of antidepressants is loss of libido or diminishing in sexual desire. And we need to really start integrating these various aspects of sexual pleasure. If our patients are feeling sad, it's more than, what are they sad about? What are they depressed about? And I think that we're very used to referring them based on the assumption that they're sad because they're living with HIV. And it's often much more multi-layered, just as it is in all of us. Very important, especially now, my pleasure population, my patient population, or my research participants tend to be people of low socioeconomic status. And among people of low socioeconomic status, we know that interrelationship violence is more common, and the ability to liberate ourselves, to liberate from these abusive environments are also less. Women of low socioeconomic status feel less capable of leaving abusive situations. And when someone isn't experiencing sexual pleasure, it really can be an indication of how safe they feel at home and what else is going on in their personal relationships. As I said, we're going to talk about one of our projects, Sweet Pea, in a little bit, but it was very interesting to me to learn that most of the participants who were engaging, they were all women with HIV, and we did qualitative research with them. Most who were engaging in sex were not experiencing pleasure. And that was a really significant finding for me. Now, this is just a nice table that helps us quantify and look at it really easily. If we're looking at mental health, we know that pleasure indicates more emotional safety, less stress, and lack of pleasure indicates depression, PTSD, high anxiety. Cardiovascular, if someone is having pleasure, then their blood flow is good. They're able to get blood gushing down south, which is exactly where it needs to be to experience optimal sexual pleasure. But if they're not experiencing pleasure, they might have some cardiovascular health problems that are not being addressed, or diabetic issues. endocrine, balanced hormones, and healthy aging. That's what sex pleasure would indicate. And lack of pleasure may be a sign of early menopause. We know a lot of women living with HIV do experience earlier aging. They might be side effects from the medications. And again, it might be metabolic dysfunction. Social, if they're having pleasure, they're going to have a better social life. And those who are lonely, one of my staff members is looking at the association between loneliness and HIV outcomes. And I thought that was a really interesting perspective. She has a lot of hands-on contact with our people living with HIV, and it's unmanaged HIV. And she really believes that loneliness is a major factor. And so she's looking into that. And our physical fitness, if pleasure, we have a healthy libido, we have healthy levels of desire, we're able to naturally become lubricated, we're able to experience orgasm. And lack of pleasure could indicate a range of physical problems that might need to be addressed. Now, so overall, what do we want to take away from this? That when we're dealing with a woman living with HIV and she's saying she's not experiencing sexual pleasure, doesn't want to engage in sex, this isn't a minimal thing like, okay, that's normal for women living with HIV, that's normal for someone your age. No, this could be a referral trigger. We might need to screen for cardiovascular risk, diabetes. We might want to review their medications. Look, are they on depression or anxiety medications? We might want to talk about psychosocial support. Are they part of support groups? Do they have the social bandwidth to even find maybe not a romantic partner, but even a social community? And then beyond that, where would they even explore finding a romantic partner? What are the resources that we can provide to help people? And the thing is, most providers just really don't want to talk about sex anyway. I wrote a paper a couple of years ago, I think it was 2 years ago. What are future doctors learning about sex? And in the background, I discussed some previously published literature that stated over 90% of doctors feel unprepared to address sexual health issues. And I talk to my colleagues all the time about this. It's the last thing that they want to talk about, especially with someone of low socioeconomic status who may be participating in high risk behaviors that they don't feel they have the capacity or the time to address appropriately. Qualitative data in the references at the end of this, you'll see there's a paper that hopefully will be coming forth soon by D'Souza that shows that HIV clinics, let's see if we can go back. Conversations in clinics are almost always initiated by patients. And those of us living without HIV might find the same situation in our own lives. It was back in 2001, I think, that Institutes of Medicine report that identified that stark racial disparities were still ongoing in clinical care. They found that even just HIV alone, almost half of all doctors treating Black patients don't even address HIV, which is crazy because Black people at the time maybe still are in Miami, that's changing a little bit, but Black people at the time were the people, at greatest risk for contracting HIV. And that Institutes of Medicine report back in 2000 showed that almost half of doctors, when HIV was addressed, the patients were the ones that initiated the conversation. And the same goes on for people living with HIV. When they're talking about sex, they're initiating the conversations with their doctors. And of course, doctors, they say there is a lack of specialized training. There's no standardized sex education curriculum in medical schools. A lot of people just personally don't feel comfortable talking about sex. And a lot of clinicians I've spoken to, it's like we talk about things that we know that we can address. I don't know how to address sexual issues, so it's one of the things that I'm less likely to bring up. So really, here's where we are. This is what's going on. We have all of these internalized stigmas that are manifesting as guilt, fear, anticipated judgment. even when women are virally suppressed, they carry this profound anxiety about disclosure and being rejected if they reveal their status. And compared to women living without HIV, and the FSFI, the Female Sexual Function Index, is a great scale. And it shows that women living with HIV in almost every domain of satisfaction, they're scoring lower: desire, arousal, orgasm. Most women know that those are issues that women with or without HIV are dealing with. So the fact that women with HIV are scoring even lower than the general population really should make us pause and think about what can we do about this. And these gaps are heavily driven by these overlapping catalysts. Higher rates of depression, we know, are among people living with HIV, PTSD, body image challenges. Sometimes medications cause, our bodies to change. And then the socioeconomic vulnerabilities that a lot of women can't afford to join a gym, can't afford nutrition counseling, and a lot of our public health systems don't provide these things. Can I go forward? So how do we reclaim joy? How do we enable pleasure in women living with HIV? We have to really promote you equals you. This is a source of empowerment. For the first time in so long, people living with HIV can actually consider engaging in sex without barrier contraceptive methods. And that is an incredible advance that I don't think enough clinicians are discussing. And what are the factors? And this is something that we can really talk about as scientists when we're dealing with women living with HIV. Let's say one of our patients wants to experience more sexual pleasure. It's important that we know some of the factors that can contribute to that, such as long-term relationships, positive body image, stable medication, and having open discussions with our partners. So that means we have to have the resources to help people develop the self-efficacy to do so. It's so important. I'm willing to die before I take water to stress this point. And when I talk about this, having open discussions, I want everyone to reflect on your own personal sex life. It is not easy to have an open discussion with a partner or a potential partner about sex, and especially about sexual pleasure. And I've often said it's much easier to just have bad sex than talk about having good sex. So imagine that you're dealing with disclosure issues, medication issues. Maybe we want our partners, or someone is going to ask their partner to go on to PrEP. There's a lot of different issues. And I think it is a burden on the clinical community to come up with the resources to empower our patients to be able to have this. So it's important that we know these factors that we're discussing. And so that we can tell our patients, that one-off, like going on Tinder, that might not be the way for you to experience your optimal sexual pleasure. Because in women living with HIV, it's these factors that really contribute to it. And then the intersection of aging. The studies show that actually the older women are who are living with HIV, the more open they are to experiencing pleasure. And that happens across all women, regardless of their health status. Women tend to experience more sexual freedom, confidence, and they appreciate pleasure more as they age. It's sort of like girls grow up like, if you have sex, you're a bad girl. You're a bad girl, so don't have sex. Don't do this. Don't do this. And then after you've had kids and you've been married, maybe divorced, and you've gone through perhaps being diagnosed with HIV or diabetes or all of the other things that we go through as we grow older, you're like, you know what? I'm not worried about anyone labeling me based on what my sexual desires are. I really am going to advocate for myself, and I want to experience more pleasure in my life. And so knowing that this increases as women age, but also understanding that, you know what, perimenopause, menopause, postmenopause are also coming along with this increased sort of psychosocial desire to engage in better sex. So women older women with HIV, while they're becoming more confident, they're also saying, hey, help me out with these menopause symptoms. It's not all about HIV. So we can turn our clinical encounters into we can incorporate or really fully integrate sexual well-being, sexual satisfaction into our clinical encounters. 4 steps. Of course, they sound much easier than they are because time is what's usually the biggest shortage in most of our clinical environments. But one, we've got to stop siloing sexual health. It's not separate from HIV. It's not separate from cardiovascular health. We have to integrate questions about desire, satisfaction, and pleasure routinely into our clinical encounters. Providers have to start initiating the conversation. And that's really, really difficult, but we've got to get out of our comfort zone and start bringing it up to our patients, recognizing that people who actually aren't engaging in intimate relationships have greater health risks than those that are. So just from a clinical basis only, you want your patients to be healthier, which means you want to proactively bring up the issue of sexual intimacy and sexual pleasure. And addressing the biology that deals with managing symptoms. So if we're screening for physical barriers to pleasure, that allows us to address regular menopause or perimenopause, aging-related symptoms. It also allows us to address potential metabolic underlying conditions, heart health, diabetes health. And then really, as we started with, really promoting you equals you, it's really empowering. Like now that we have managed, we can achieve viral suppression. We actually really know how to do that. But once we get there, you can also have barrier-free sex and really trying to get our patients on board with this. What are our steps to having barrier-free, pleasurable sexual relationships? And that's really a nice way to reframe it. And so what are the next steps? How do we get there? Because right now there's huge, ginormous data gaps that really aren't going to let us get there. One of the projects that I've referenced a couple of times throughout this presentation that we're working on is our Sweet Pea project and sexual wellness education experiences and treatment of positive women. First, there was no sex education assessment for people living with HIV. So we went on and we developed one. There's different clinical assessments. I think it's the HIV, it has 3 Ps, one of those assessments, but it's really focused on forward transmission. And there's school-based sex education assessments. So we took a couple of these validated instruments to 30 women living with HIV in Miami, and we asked, what do you think about these questions? Are they using the right words? Are they important to you? Are there questions that are missing that we're not asking? Do you think that these are these important or are they not important? And how would you feel if someone asked you questions in this way? So we did a couple of focus groups and they were so excited. Like we had to turn people away. They're like, oh my gosh, finally, we're going to address sex. Finally. So after we developed the survey last summer, we interviewed 30 women using this modified survey, or this adapted survey. The data is currently under analysis. Oh, did I do it? No, but I did pull it up. But the data is currently under analysis. I meant to incorporate our poster. 2 medical students that we work with just won. They won first prize in an OB-GYN at an OB-GYN conference for their poster. But what it showed is that women aren't getting, 80% of women did have school-based sex education, but 0% had any discussions of pleasure. And very few had any discussions of sex education post-diagnosis beyond forward transmission. So the goal of using this data is, one, to demonstrate that there is a need for women living with HIV to get sexuality education. And then hopefully we'll find some support to develop. I use community health workers in all of my research, community health workers interventions. And I would like to design a community health worker-led sex education intervention that can be done in the clinic before or after their appointments. And the other thing that I'm working on is a contraception and abortion project that would start a new line of research here at the medical school for women living with HIV, looking at their access and utilization of contraception and abortion resources here in Florida. I recently submitted this application to the Society of Family Planning in Florida. And what we know, why is this important? Because unplanned pregnancies diminish sexual pleasure. And the unplanned pregnancy rate amongst women living with HIV is almost 80% compared to the general population, where it's 50%. And in just this year, the Florida DOH, they cut our AIDS drug assistance program by 120 million. Some of it has come back. It's moving. I don't watch the news, so I'm not as current on exactly where it is today. This occurred right after Florida failed to expand Medicaid, which means people of color, and why I say people of color, because people of color represent the largest group of people living with HIV in Florida, but people of color now represent more than half of the state's uninsured population. Black women make up almost a quarter of the people who use Title IX clinics, like Title V clinics, such as Planned Parenthood, but Florida is actively defunding them. So basically, if you're an uninsured Black woman, which is the majority of women living with HIV in the state of Florida, you have no access to reproductive care, including abortion. And now we have, of course, this 6-week ban on abortion. And the main reason why women without access to healthcare delay abortions is because they need to raise money to get the abortions, which is why they get them after 6 weeks. So predictably, all of this is just perpetuating these persistent disparities in reproductive outcomes. And this is just data. I see that we're out of time. So this is just data just really showing that having an unplanned birth, it diminishes future sexual pleasure. So addressing the access to contraception and abortion care is another way that we can really advocate for sexual justice and reproductive justice for women living with HIV. So HIV care keeps women alive. They're not siloed pleasure contraception. These are fundamental human rights. We need to integrate sexual health, contraception, and abortion access into HIV care. And we've already mastered suppression. So now we have to champion the right to sexual expression. Some of the references, all of the references about my papers are not in there. Sorry, but I can include them and send them to the facilitators. Thank you.
Great. Dr. Kenya, we love your passion. Clearly, we could have dedicated more time to this. And folks, please put questions in the chat. We'll get to a question and answer session after the second set of speakers. But with this talk behind us now, we move forward to the next one in our second two sets of speakers, Dr. Christina Mudsney. And Dr. Mudsney obtained her medical degree at Texas A&M University Health Sciences Center for College of Medicine and completed an internal medicine residency and her infectious disease fellowship at the University of Mississippi Medical Center. She joined University of Alabama UAB ID faculty in 2010 and obtained her Master's of Science in Public Health with a focus on epidemiology at UAB's School of Public Health in 2017. And her clinical and research interests focus on HIV and sexually transmitted infections, particularly vaginal infections. Her current funded work, R01 research, focuses on pathogenesis of bacterial vaginosis, in addition to the optimal treatment regimen for trichomoniasis in women and men. And Dr. Mudsney is a tenured full professor at UAB in the infectious disease division with a secondary appointment in epi and obstetrics and gynecology. She's the medical director of UAB's Vaginitis and Sexual Health Research Clinics, as well as the chair of UAB's Institutional Review Board. And she will be joined by Sheraton George, who's a fourth-year PhD candidate in Dr. Mudsney's lab. Sheridan researches microbial interactions during the pathogenesis of incident bacterial vaginosis, and their joint talk is entitled Updates on Bacterial Vaginosis, Partners, and Pathogenesis. Over to you.
Thank you so much for that introduction. Here are some of our disclosures. I do not have any, and then this is the list of all of Dr. Mudsney's disclosures. So the composition of the vaginal microbiome is affected by many different factors, such as race and ethnicity, genetics, diet, sexual behavior, hygienic practices, and many other components. And unlike other human microbiomes, such as the gut, the healthy vaginal microbiome is normally has just one singular lactobacillus dominating it. And these lactobacillus species are considered to be protective by producing lactic acid and keeping the vaginal pH low. There are 5 classifications of the vaginal microbiome. These are known as community state types, or CSTs, and we have 4 CSTs composed of a dominant lactobacillus species, and we have 1, which is CST4, which is microbially diverse. So CST4 commonly indicates bacterial vaginosis, or BV, and BV is a form of vaginal dysbiosis where there's an overgrowth of facultative and strict anaerobic bacteria and a depletion of those protective and native lactobacillus species. The 3 that we mostly focus on are Gardnerella, Prevotella, and Phaniessa vaginae. And these normally colonize to create a polymicrobial biofilm on vaginal epithelial cells and raise this vaginal pH since the lactobacillus species have now been depleted. And this biofilm is developed using several virulence factors by these BV-associated bacteria, and it's associated with very high recurrence rates of up to 60% within the first year of antibiotic treatment. And BV is the most common vaginal infection worldwide. It has a prevalence of about 23 to 29% in each of these regions around the world. And it's associated with several different adverse health outcomes. To name a few, there's an increased risk of infertility, adverse birth outcomes, postoperative gynecological infection, increased risk of pelvic inflammatory disease, and increased risk of cervical cancer with HPV co-infection. However, the most important one that I want to talk about today is the increased risk of acquisition of STIs and, most importantly, HIV. So there is a well-established crosstalk between BV and HIV susceptibility. BV increases the susceptibility to HIV, while HIV also increases the susceptibility to BV, as women living with HIV have a higher prevalence of BV than women living without HIV. And this is thought to be driven by a dysregulation of the immune system. So as BV-associated bacteria cause local inflammation, T cells are activated to come address that inflammation, and T cells are the target of HIV. So this likely increases the transmission of HIV in the context of BV. However, despite the importance of this relationship, the underlying causes and mechanisms of BV are not fully understood, limiting our ability to fully address its role in HIV susceptibility. So in order to address this, that the cause of agent of BV is unknown, we performed an instant BV pathogenesis R01 study where our objective was to investigate the BV biofilm formation over time among women who developed IBV using PNA FISH, focusing on those 3 key BV-associated bacteria that I listed before, Gardnerella, Prevotella, and F. vaginae. And our hypothesis was that among women who developed IBV compared to healthy controls who did not develop BV, Gardnerella species would be the primary colonizer prior to BV, with subsequent colonization by Prevotella, followed by F. vaginae as a secondary colonizer. So we enrolled women with an optimal vaginal microbiota, ages 18 to 45, to self-collect vaginal specimens twice daily for 60 days. And throughout this study time period, each specimen was tested for BV by a Nugent scoring, and BV was diagnosed by a Nugent score of 7 to 10 on 4 or more consecutive specimens. And women who developed BV were matched to control participants who did not develop BV, and their specimens were aligned by menstrual cycle days, as shown in this figure here. Then these aligned specimens from BV cases and matched controls 14 days before BV to 3 days after BV were hybridized with peptide nucleic acid probes and then fluorescently imaged using a slide scanner for fluorescent microscopy. And here is our overall cohort characteristics. We ended up having 18 women who developed BV over the study, and they were matched to 18 control participants who did not develop BV. And these were effectively matched 1-to-1, signified by the p-value. No p-value was significant, so this matching was efficient. Similar to our hypothesis, Gardnerella species were significantly higher 5 days before BV in cases compared to controls as the first species that was significant. I will note, however, that Gardnerella species were higher throughout this whole timeline, starting at 14 days compared to the controls. Additionally, F. vaginae was significantly more abundant in cases over controls on the day of BV, suggesting that it does have a role as a secondary colonizer to the BV biofilm. However, unlike Gardnerella and F. vaginae, Prevotella species were not significantly different at any particular time on our timeline of 14 days to 3 days after BV. However, in IBV cases, when we pooled across the whole timeline, BV cases did have a significantly higher presence of Prevotella species than controls. So to conclude, in our IBV cases, we had elevated Gardnerella species 14 days before diagnosis and probably even extending past 14 days. We had a significant abundance of Gardnerella species 5 days before diagnosis, significant abundance of F. vaginae on the day of diagnosis, and there was a higher abundance of Prevotella species. However, its longitudinal role is unclear as of now. And in our healthy controls, there was a relatively stable abundance of Gardnerella, Prevotella, and F. vaginae over our timeline of interest, and there was no point where the controls had a higher abundance of BV-associated bacteria than cases. However, in a R01 renewal, we are going to be expanding upon these results, particularly looking at different species of Gardnerella and Prevotella. So you may be asking at this point, where are these bacteria coming from? Because they are significant at these certain time points, but how are they even colonizing?
All right, so we're going to sort of move into the next part of the talk for this. So as Sheridan mentioned, where are these bacteria coming from? And I think the field is moving more and more towards, is BV sexually transmitted? That it potentially is sexually transmitted as an incident case of BV. So I do want to sort of clarify that in saying that I do think the pathogenesis of a new case of BV is different than the pathogenesis, particularly of recurrent BV, which Sheridan mentioned is very common among women. So this slide, we have data for and against whether BV is an STD. We published that about 6 or 7 months ago. I could talk about this slide really for an hour. I know we don't have time for that, but there is some data or a lot of data for sexual transmission and less data against sexual transmission. But the part that I'm really going to focus on for the end of this talk is the partner part of this. And so I want to really get into these BV male partner treatment trials. And so part of this is that there has been successful BV male partner treatment trials, most recently one published in the New England Journal of Medicine last year, which we'll get into in a few minutes. But there has been failure of other male partner treatment trials. And so why did those trials fail is something I wanted to talk about today. Next slide. So originally in the 1980s and the 1990s, there were 6 BV male partner treatment trials that were conducted. I have a big summary table listed here. So I'm not going to talk through this entire table right now, but I did want to mention these trials are very heterogeneous if you compare the methodology between all of the trials. All of the trials did use the AMSEL criteria as a primary outcome for their BV definition. They did not use the more rigorous Nugent score in their studies. Also, the men themselves were not randomized in these trials. The investigators relied on the women to actually deliver the dose of medication to the men. So that's an important point of these older trials compared to more recent trials, which did include men in their enrollment. Additionally, the doses of the medications used in these older trials are much different than how we treat BV today. And for example, a single 2-gram dose of oral metronidazole was used in many of these studies, which we know does not effectively treat BV today. Next slide. So there was a meta-analysis, systematic review and meta-analysis of these older BV male partner treatment trials published in 2012. And it was noted that, as I mentioned, these trials had multiple limitations. Again, the medication was delivered to the male by the female, so the study teams were not having direct contact with these men, which leads to a lot of variability in what could have happened. Many of the trials had insufficient power to detect reasonable effect sizes. Randomization methods in some were deficient or insufficiently reported. Adherence to therapy in men was infrequently reported because, again, they were only getting the information from the women that were in the studies. And again, many of the treatment regimens used were inferior for BV treatment. Next slide. So more recently in modern times, my colleague Jane Schwebke and other colleague Jack Sobel here at UAB and also at Wayne State University, we were all able to participate in a more modern BV male partner treatment trial. This was published now 5 years ago. And we tried to overcome several of the limitations of these prior 1980s, 1990s trials with a sufficient power calculation. We randomized the men face-to-face, and they were also receiving, in the intervention group, the multi-dose oral metronidazole treatment regimen, which is the most common regimen used to treat BV in modern times. And we also tried to improve monitoring of male partner adherence here in this study with a pill bottle review. And of note, this study was double-blinded. So the men were either randomized to placebo or metronidazole, but they did not know, the investigators and the participants did not know which treatment they were assigned to. Next slide. Despite trying to overcome many of these methodological limitations of these older male partner treatment trials, unfortunately, this study was not efficacious for BV male partner treatment. So we had 214 couples that got enrolled, and in the intent to treat population that you can see on this slide, there was no significant difference between treatment arms for the primary outcome, which was recurrent BV in the female partner. BV treatment failure occurred in 81% of women whose men were in the metronidazole arm versus 80% of women whose men were in the placebo arm. However, women whose male partners adhered to the study medication in the intervention arm were less likely to fail treatment. And so I did want to mention, and I didn't mention a minute ago, women that were enrolled in this trial had to have a history of recurrent BV. So they had to have at least 3 episodes of BV in the past year, in addition to a current episode of BV when they got enrolled in this trial. So we think one of the reasons why this trial was a null result was that because these women were heavily BV treatment, heavily BV experience and also BV treatment experience. And we think they may have had very mature BV biofilms that had developed and may be difficult to eradicate. And the BV male partner treatment intervention may have been potentially too late for some of these women by the time they got in this study. Next slide. So here's sort of summarizing these findings and potential reasons why they were negative. I did, again, the first bullet point, I mentioned some of these women or all of these women were heavily BV experienced, and potentially the oral metronidazole itself for them plus their male partner was insufficient to eradicate. There was lack of some adherence to multi-dose metronidazole that occurred in some couples. So we had postulated at the time maybe to consider using a single dose medication in future BV partner treatment trials, which oral sagnitazole is a single dose that is FDA approved for BV treatment since 2017. So we had considered using that in a future trial. Additionally, oral metronidazole alone in the men may not have effectively cleared BV-associated bacteria from the penile microbiome and or prostatic or seminal vesicle reservoirs. Next slide. So most recently, I alluded to this New England Journal of Medicine paper, which came out last year. So this was the most recent BV male partner treatment trial that has been published. It was done by Catriona Bradshaw and colleagues in Australia at the Melbourne Sexual Health Clinic. And so this study was not double-blinded. This was an open label study. And they did include women with any kind of BV. They could just have an initial episode of BV. They included women with recurrent BV. It wasn't just recurrent BV women like our trial was. And they had to have a regular male sex partner for at least 8 weeks for the couples to be enrolled in this study. And so the men got randomized either to placebo, which was nothing in this study because it wasn't blinded, or multi-dose oral metronidazole in combination with topical clindamycin cream to be applied to the penile shaft, both of those for 7 days in the men, and they did treat the women per standard of care. So in contrast to our trial, this trial did find a significant effect. In the modified intent to treat population, BV recurrence occurred in 35% of women in the partner treatment group versus 63% of women in the control group, which corresponded to an absolute risk difference of 2.3 recurrences per year less in the male intervention group. So this was a very exciting finding for the field with a very rigorous trial that had been done. And we were able to write an editorial with our thoughts about that. Next slide. Since this trial was published, several of national and international guideline societies have published their recommendations for BV male partner treatment. So ACOG was the first society here in the US to publish recommendations. So they did update their recommendations in December of 2025. So now they are in support of concurrent sexual partner therapy with combination oral and topical antimicrobial agents for male sexual partners of adult patients with recurrent symptomatic BV. And they say that shared decision-making regarding concurrent sexual partner therapy is recommended for adult patients with recurrent symptomatic BV who have same-sex partners, so women who have sex with women, and for patients with a first occurrence of symptomatic BV. Next slide. Also, the International Society for the Study of Vulvovaginal Disease has come out with some recommendations. This was published in February of 2026. And so they basically are a little bit tighter on their recommendations for this in the couples. So they say they do recommend BV male partner treatment if all of the conditions listed here on this slide are met. Confirmed diagnosis of BV in the female index case, symptomatic BV in that case, and at least 3 confirmed episodes of BV in the past 12 months. So they're mainly recommending BV male partner treatment in women with an active case of BV and also with a history of recurrent BV. In contrast to ACOG, which is giving a little more leniency to people with sporadic, uncomplicated, acute BV. Next slide. So I did want to mention what we're currently doing at the UAB ID Vaginitis Clinic. And so my colleague Olivia Van Gerwen and I opened a vaginitis clinic at UAB in 2020 during the COVID pandemic. And so we are a tertiary referral center. We see patients from all across Alabama, Florida, Georgia, Southern Tennessee, really with recurrent BV, recurrent trichomonas, and recurrent VVC infections. And so we've sort of pioneered integrating BV male partner treatment into our practice. And so we actually have started doing BV male partner treatment for some patients starting in March of 2025 when the New England Journal of Medicine paper came out. I have talked to Catriona Bradshaw extensively about how they do it at their settings in Australia. They have found the best way to do it with the men is obviously many of these men do not come with the women to their clinic visits. So they're doing telemedicine visits with the men after they've seen the women in clinic. So we've really set up this model at our clinic where I try to do a telemedicine visit with the men within a few days of seeing the female in the clinic. And it's best for the partnership if both the female and the male are taking the treatment at the same time. So we try to do these telemedicine visits with the men as soon as possible. And we are prescribing the combination oral metronidazole and the topical clindamycin cream. I do want to mention for the prescription of the topical clindamycin vaginal cream for the men. So I don't know what it is at other institutions, but like in our medical record, our electronic medical record here at UAB, we have to order it under vaginal clindamycin cream. And so I do write in the instructions field of the prescription that it is for the men to use topically on their penis. So the pharmacist understands what this is being used for. The Australian group that did the partner treatment trial also has a lot of great patient, pharmacy, and clinician educational handouts available on their website that we do give to all the female patients to give to their male partners. And so that sort of helps in people understanding how to do this intervention. And also some men don't want to do telemedicine visits with us. They want to go to their primary care provider. So we just help facilitate giving them handouts and resources on the new information to give to their PCP who may not be aware of this. People have asked me to prescribe expedited partner treatment for BV. It is not legal currently in the state of Alabama. Our colleagues in the state of Maryland, Anna Powell and others, have gone to their state legislature and a bill was written, which just was enacted 5 days ago on June 5th, 2026. And so BV EPT is going to be legalized first in the state of Maryland in this country. So I'm hopeful to see other states follow on this in the near future. Next slide. So I know this is the end of our talk. I hope we have a few minutes for questions. And we acknowledge everybody on our BV pathogenesis research team and also everybody working at our UAB Sexual Health Research Clinic. So thank you so much for inviting us. And I will turn it back to our moderators.
Very great. That excellent talk as well. You do have a question about how to deal with the biofilm formation if it exists in women with recurrent BV. Maybe you can address that one for us.
Yeah, so definitely. So we think BV by definition is a biofilm infection. So definitely, I think women that have recurrent BV are having trouble eradicating this biofilm. And so why are they having trouble eradicating the biofilm? Is the biofilm too mature that current BV recommended therapies are not sufficiently eradicating it? Are they getting reinfected with BV-associated bacteria from untreated male partners when they're having unprotected sex after their BV treatment? And so I think, as I was mentioning earlier, I think the pathogenesis of recurrent BV is a little more complicated than just a new case of BV. And it really calls out the field for many years now, decades, has been calling out for improved BV treatment to definitively eradicate this biofilm. And we're just not there yet with the current treatments that we have. There are clinical trials in development, but currently, it may be that we're moving towards combination antimicrobial therapy with antibiotics and biofilm disruptors, but none of that is fully fleshed out right now. So it's really $1 million question, how to best treat recurrent BV.
Great. And Dr. Mussey, there's another question there. I'll throw something out just in our last few minutes, to both of you. Are we missing an opportunity in vaginitis clinics about having a discussion about sexual pleasure in general? It seems we put two bookend talks together, but I wonder if it's the whole story. It's an opportunity.
Yeah, absolutely. I'll let actually Dr. Kenya, you want to comment
Sure.
on that?
What I found most interesting, what made me, I started research before I became a sexologist. And in the beginning of the epidemic, or not the beginning, when the medication started working, we started being a little more relaxed. And I asked women, how did you contract HIV? And almost all of them said that when they explained their relationships, none of them were pleasurable encounters. So that's actually one of the biggest motivating factors that inspired me to go on and get additional education to become a sexologist. And then I posed the same questions to all the clinicians I was working with, and they said the same thing. Basically, I found out anyone we work with, whether they're patients or our colleagues, nobody's experiencing sexual pleasure. I think it's so important. It's so important to the clinical encounter. Absolutely. Absolutely. Especially because most of our patients don't have a history of sexual pleasure. And now
Right.
they're with this whether it's BV or HIV or whatever they're living with, they don't even have experience with sexual pleasure.
Yeah, I definitely think it's an excellent point. Whoever made that point, I think it's something we all need to be more cognizant of. I personally need to be more cognizant of it because these women these infections impact their mental health and their sexual health, and they don't feel empowered to enjoy sexual pleasure. They have an odor, they have this discharge, they feel dirty. Some of the women say, oh, the men are telling them this is a woman's problem, this is my problem. I think the partnership needs to take more accountability. The men need to take more accountability. It's not just a woman's problem, in my opinion.
Great. Well, thank all three of you for just fantastic talks. We do have, we've got a September 9th symposium or webinar coming up, and that should be on your calendar. You see that there is a questionnaire that you can fill out to rate the speakers so we can give them feedback on how they've done. And we will be sending out a survey to understand who might be presenting at the 26th Annual International AIDS Conference in Brazil, so we can set up some walking poster tours as well. And I want to thank all three speakers for just really energizing talks, really knowledgeable talks, and for the attendees. We had great attendance today at the webinar. Thank you all.